Welcome everyone to today's webinar as part of our series for Antimicrobial Awareness Week. And again, just before we start, I'd just like to acknowledge the land on which we are today and recognise Aboriginal and Torres Strait Islanders from wherever you are watching today. And welcome to everyone online. I can see many of you have been attending several of our webinars. I hope that you found it as fantastic as we have. Today we have a really fantastic lineup of speakers, all of which are really becoming leaders in their own right in these various areas. And our first speaker today that I'm really very pleased to introduce is Dr. Abby Douglas. She is an infectious diseases physician who has literally just submitted her PhD and has been doing groundbreaking work in the area of neutropenic fever, and will be talking to us about a very exciting randomized controlled trial which she undertook and how that's going to drive new practice for diagnostics and management of neutropenic fever. So take it away, Abby.
Unmute myself. Thank you so much, Kaz, for the introduction. Can everyone see my slides? I will go into the randomized trial, of course, but I will give a little bit of background and other supporting evidence as part of the PhD along the way. So disclosures is essentially NHMRC CRE funding, PhD scholarship through the Uni of Melbourne, and some small grants from Melbourne Health and Gilead Sciences fellowship grant and unrelated honoraria. So the background to this, why does this all matter, is that in high-risk neutropenic fever, which are those patients who have low neutrophils for a prolonged period of time, in typically at least 7 to 10 days, is that they are at strong risk of fever and infection. But unfortunately, they often lack localizing features to tell us where the infection is coming from. And so we do rely heavily on diagnostic tests to tell us what's going on, but the current standard of care tests are not sensitive nor specific for causes of neutropenic fever. And oftentimes, given the concerns about septic deterioration and also invasive fungal infection, there's often prolonged and escalating antibiotics used empirically, which is not necessarily desirable from an antimicrobial stewardship perspective. So just as a background, setting the scene in Australia, utilising the hospital NAPS data from 2014 to 2018, we looked at 94,000 prescriptions in adult inpatients who are not in ICU, 662,000 adults, in the subgroups of non-cancer and groups of haematology, BMT and oncology across 454 facilities, in order to look at empiric prescribing for neutropenic fever and also antimicrobial prophylaxis and antifungal prophylaxis. But for the purposes of this talk, I'll focus on neutropenic fever. And in essence, looking at appropriateness of neutropenic fever, somewhat reassuringly, overall, the appropriateness was quite high across all groups, non-cancer, oncology and heme BMT, between 83 and 90%. However, there were some areas that were of concern and need improvement potentially, including in heme BMT was the fairly high rates of carbapenem use, and about 1/5 of them were deemed inappropriate. And so you can see in this graph here that purple is tazocin, which is our workhorse antibiotic for neutropenic fever. But there's quite a lot of magenta here, the meropenem in the heme BMT group, as well as quite a lot of black, which is vancomycin, and that was another antibiotic identified as being quite frequently used and often inappropriate. And I think that really just goes to show that we really don't know what we're doing sometimes with patients when we don't have anything to target and there's a lot of empiric therapy used. So the current persistent neutropenic fever diagnostics, as I mentioned, are not fantastic. And in the setting of persistent or recurrent fever, at least usually 3 to 4 days of fever that's unexplained, we typically perform an HRCT chest plus or minus abdopelvis, which I'll talk about in a second. But HRCT is wonderful in that it's very sensitive, but it's not specific. And there are a lot of other reasons we can see abnormalities on the scan. And to be honest, it doesn't necessarily help us too much. The question of whether a CT abdo-pelvis or other areas of imaging such as sinuses empirically is helpful is even more under question. There's really not much data to guide us at all, but it is used and is not that necessarily super specific or sensitive. So in that setting of having not great diagnostic imaging, there's been some interest in looking at FDG-PET CT as a method for being able to identify more sites of infection and potentially rule out sites of infection. And this is just a summary prior to the RCT of studies that had been in the literature. Essentially, quite small studies, not randomized, different definitions of when you would perform a scan as well. But essentially, the pattern was really that there were additional sites of identified infection in PET that weren't detected on CT that were likely to be helpful and impactful, and certainly raised the question of should we explore this further. This is just an example of a PET scan in this patient group where a patient had persistent fever, neutropenic fever, and as you can see, the top left is a CT where you really wouldn't say that there's particularly a significant abnormality, certainly not focal abnormality, but on the FDG-PET component, there's clearly 2 areas of avidity that are abnormal, and they turned out to be pyogenic liver abscesses, gram-negative liver abscesses. This was a summary table that's a bit busy, but I'll talk you through from the review article I did at the start of the PhD, looking at opportunistic infections and what was seen on PET in the literature. And particularly in fungal infection, it was quite promising. Lots of reports of detection of Aspergillus, Candida, Cryptococcus, etc. SUV max, which is a marker of hotness of a lesion, is used to try and tell us whether something's malignant or benign. And typically the rule of thumb is 2.5 and above is more likely to be malignant. But actually in fungal infections, the lesions are actually quite hot, which does have some problems as far as differentiating with cancer, but equally they light up. And so that's really helpful on a PET in someone who doesn't have a solid cancer like a hematology patient. If there's that area lighting up, that's quite helpful to X marks the spot. So again, highlighting another potential area for improved management. Now, in the interest of time, I won't try and spend too much time on this, but this was another part of the PhD looking at our experience at the Peter Mac PET Centre, rich experience with PET, and how many proven probable invasive fungal infections were detected on PET in that time, and looking at the characteristics of that. And the questions being, did PET perform better than conventional CT? Did PET detect more dissemination? And could PET give us more information about response to therapy? And so 48 invasive fungal infections in 45 patients were found, basically searching the PET report database of suggestive of fungal infection. And many patients were pancytopenic, some were isolated neutropenia, lots of lymphopenic patients. So those with quite immunosuppressed were included in this group. And not surprisingly, a lot of Aspergillus was seen, and then some Lamentaspora scaediosporum, which is quite novel, not a lot of reports in the literature about that, and some yeasts. And again, highlighting that the median SUV max was very high. These are very hot lesions. And just the money slide from this paper was that whilst detecting the original infection was fairly similar in CT to PET CT, PET was more likely to detect dissemination than CT, and in particular was giving us more information about response to therapy. So in patients who had both PET and CT at initial diagnosis and at follow-up, I'll highlight this line here with the 18 patients. 18 out of 18 on PET had significant improvement in the FDG avidity, suggesting response, versus only 7 in the CT showing significant improvement in the lesion, which therefore there's that discordance in 11 patients where clearly PET was showing that things were improving or resolving. And here's an example of that, where on the top left, you've got your CT at diagnosis with a clear abnormality in that left lower zone, which was Aspergillus, which was very hot. And then in follow-up after 3 months of standard therapy, there's actually quite a significant lesion still there on CT, and that would make us quite concerned. But there was really no avidity left at all, and that patient did well with the standard therapy. So suggesting that it's giving us that early indication of response to therapy. And so that's quite helpful from a neutropenic fever perspective, because we are concerned about invasive fungal infection in these patients. So that also helps feed into the RCT that I'll mention now. So the Pippin study is the study listed here that was published in the Lancet earlier this year. And the aim of that study was to compare the impact of PET to conventional CT for the management and outcomes of persistent and or recurrent neutropenic fever in those high-risk patients, the ones having allotransplant, autotransplant, or induction and consolidation chemotherapy for acute leukemia. So the methods were that this was a prospective multi-centre open label randomised study in Australia at Royal Melbourne and Peter Mac, comparing FDG-PET CT to conventional CT in, as I mentioned, those high-risk patients who had persistent was defined as more than 3 days of fever, and recurrent fever was when they had resolution of that initial fever, but then recurrence at least 48 hours after resolution of fever. And those excluded were those with poor renal function because of the contrast load with CT potentially, pregnancy and allergy to iodinated contrast. And the primary outcome was a composite endpoint of antimicrobial rationalization, which was made up of stopping treatment intent antimicrobials, so either stopping all antibiotics of a treatment intent or stopping targeted antifungal therapy or antiviral therapy, commencing a targeted antimicrobial, so commencing antifungal therapy, commencing antivirals, or starting any antimicrobial antibiotics whatsoever, and refining antimicrobials, which is the vast majority of patients are often on broad spectrum antimicrobial therapy. And then what did they do with those antibiotics? And that can be either narrowing spectrum of therapy or broadening spectrum of therapy. And we'll talk about what happened in those subcategories in a minute. So as I mentioned, patients were recruited from Peter Mac and Royal Melbourne. We tried to recruit patients when they were relatively well and able to, have a good conversation and consent. So that's usually quite doable with transplants, a bit more difficult with acute leukemia when they're coming up to their diagnosis and taking that all in, having the chemotherapy plans and whatnot. But we did quite well with recruitment, which I'll show in the next slide. Essentially, patients then had their chemotherapy and or conditioning and were observed in hospital. If they didn't develop neutropenic fever, of course, they didn't enter the study. If they developed neutropenic fever, they were commenced on their empiric standard antibiotic therapy as per Australian guidelines, and a standard septic workup was performed. If that fever settled by 72 hours and did not recur during that neutropenic period, they were not randomised. But if they did have ongoing fever or recurrent fever, they were randomised 1-to-1 to PET or CT. And that imaging result was available to the clinicians to act on as soon as the result was available. And as we mentioned, we looked at antimicrobial rationalization, but also other changes in management like targeted sampling and drainage, as indicated by the scan, removal of prosthetic materials such as a line, ICU admission, hospital mortality, and length of stay. And so the power calculation was such that we required 73 per arm, 146 overall, but that did allow for a 10% dropout. Some of the outcomes required adjudication, and in that setting we assembled 6 adjudicating panels, which comprised an ID physician and a haematologist, and they were asked to assess the impact of the randomised scan and the final causes of neutropenic fever at the end of the day, based on all investigations. We also had the investigator panel, which was Monica, Kaz and myself, which assigned an invasive fungal infection category if a patient had potential invasive fungal infection, using strict criteria, assigned the antimicrobial rationalization categories and acted as a third umpire as required. So each patient had a full summary of their admission, including their risks, their prophylaxis, how far into neutropenia were they when they developed their persistent fever, how unwell they were, and then any symptoms, fevers, antibiotics, microbiology, imaging, and other important other things that occurred during their admission, including ICU. And so based on that full summary and the scan results, the adjudicators made their assessments. And in one of the assessments they were asked, as I mentioned, was the causes of neutropenic fever, and they could be several. It may be entirely unclear, but if there were causes, they could be non-infective and multiple, and infective and multiple, and were classified as fungal, viral, bacterial, or a clinically defined infection that couldn't be subcategorized. So looking at recruitment, there were about, so I can't see, but about 300 eligible patients. And we had very good uptake, really, of 276 patients who consented. Some of the other people were too unwell to really be approached. And as I mentioned, these patients were kind of potential candidates. They weren't necessarily going to be randomized unless they had that persistent recurrent fever, which 153 of them did. A very small number were not able to be randomized due to acute kidney injury and missed entry. 147 patients were randomized fairly equally to CT and PET. And then a small number weren't able to have their scan as per protocol. They might have been too unwell to go to the scanner, or the team thought it wasn't indicated anymore. And likewise on the CT side, PET side. And then in the protocol, we had allowed for patients to re-enter on a subsequent treatment cycle, say if they had another chemotherapy cycle or transplant, because we were concerned about recruitment numbers. But actually, we had very good recruitment numbers, and with a very small proportion being repeat entries, for the final statistical analysis, it was much more statistically robust to exclude the repeat entry patients. So we ended up with a final primary outcome cohort of 69 in CT and 65 in PET. The cohorts were fairly well balanced, and when you look at the types of allo, transplant, auto, and leukemia, similar proportions. Autos were very low representation, and that's essentially because many patients didn't meet the criteria for persistent or recurrent fever, and I think that just shows that autologous transplants are actually far lower risk of this issue. And a strong proportion of mold active prophylaxis. Duration of neutropenia at time of scan, at randomization, were very similar between the arms, as was the overall duration of neutropenia. So I think that was, they were quite well balanced as far as risk of infection. And time from randomization to scan was actually very good, even in the PET arm, of just over a day waiting for a PET and 23 hours for a CT. So just quickly, this is the distribution of persistent and or recurrent fever in the PET and the CT groups, and they were very similar between the arms. The SIRS criteria meeting the median in each group was 4, so these patients were unwell, but similarly unwell. Crossover within the 96 hours of scan, which was when we assessed the primary outcome, was similar between the arms, 5 in PET and 3 in CT. Crossover meaning they had the alternative scan post the randomized scan. The primary outcome was that composite of rationalization of antimicrobial therapy, and essentially there was a statistically significantly higher rate of rationalization in the PET compared to CT arm, with an odds ratio of 2.36. And what comprised this primarily was refining antimicrobials, and quite nice to see and reassuring that it was actually PET patients were far more likely to have their antimicrobials narrowed compared to CT, which is a desirable stewardship outcome. Also trends to more likely to stop antimicrobials and less likely to start, but small numbers. We did some sensitivity analyses. We retained the re-entries, and there was a similar odds ratio, but just crossing the 0.05 p-value. But again, we said if you're double counting some patients, that's actually not as statistically robust without having some fancy statistics. That was so that analysis is, you have to take it with a grain of salt. If we excluded the patients who had a crossover scan within 96 hours, a very similar pattern of impact of PET versus CT was seen. Looking at what exactly happened with these patients, as far as the backbone of antimicrobials that the patients were on at the time of scan, About half of patients had been escalated up to meropenem, which is not surprising. And then a third were still on tazocin and small numbers on the other antibiotics. And what tended to happen was that there was more likely to be de-escalation from meropenem in the PET arm compared to CT, likewise with tazocin, and actually a lot more likely to cease vancomycin or other gram-positive cover compared to CT. So these are desirable changes that we were observing. And conversely, sorry about the conversely, CT arm were more likely to commence or escalate up to meropenem and more likely to escalate up to adding vancomycin or other gram-positive cover. So both correlate with PET being better for antimicrobial stewardship outcomes. Also, pleasingly, the IV to oral switch was more likely in PET. So 18 patients had IV to oral or no antibiotic switch within the 96 hours of scan versus only 11 in CT. The actual length of antibacterial therapy adjusted for inpatient stay was not statistically significantly different, and it was more the spectrum of therapy that was different. Other impacts of the scan were similar, not statistically significantly different, same rates of CBC removal, a trend to more investigations in the CT arm, and most of those were bronchoscopies based on non-specific changes on the CT, and a trend towards new diagnosis and site of infection in the PET arm, but not significantly different. Length of stay post-scan was 3.5 days median shorter in PET compared to CT, which was a kind of a nice finding, obviously a secondary outcome, but interesting to see and helpful. No difference in ICU admission or 6-month mortality. So safety-wise, there was certainly no signal for worse safety outcomes despite having that rationalisation of therapy. And we also did some intention to treat analyses on ICU admission and mortality, and they were very similar. As far as causes of neutropenic fever, I won't spend too much time on this on the interest of time, but essentially about 80% of patients had an infective diagnosis, and many had multiple infective diagnoses, 2 or sometimes 3 or more. And just this helps illustrate what was being found on the PET versus CT. Proportionally, there were more microbiologically defined infections in PET compared to CT, and they were in various sources of infection, including the bowel in particular. And there were slightly more proven probable fungal infections compared to CT. But I think the major difference that really was striking was that there were more proportionally clinically defined infections in the CT arm. And clinically defined means that there's no pathogen identified. And so we do have to take it with a little bit of a grain of salt. And really what we were seeing was far more pneumonia, pneumonitis, possible pulmonary fungal disease diagnosed on CT. And these patients had bronchoscopies and didn't end up having an upgrade of their diagnosis to proven or probable. And these were, fairly non-specific findings on CT, which I think builds that argument that CT is finding a lot of things, but how to interpret them, are they real? So these were just a couple of examples of findings. This is obviously quite a barn door example of an invasive fungal infection with a nodule with beautiful kind of surrounding ground glass that's very avid on PET. And then this is a nice tunnel site infection of a Hickman line. In the interest of time, I won't go into this in too much detail, but suffice to say that when we did some exploratory subgroup analyses between chemotherapy and transplant subgroups, they both showed that similar pattern of more likely to narrow spectrum of therapy and the trend to a higher primary outcome in the PET. And likewise, even if you had a negative scan versus a non-negative scan, there was again that similar type of pattern of more likely to narrow spectrum. Crossovers, all in all, were fairly common. These patients can have ongoing fevers and people are trying to find causes. But I think the most important take-home message from this image is basically that while in the PET arm, there were 6 patients who had a scan for ongoing fever, all in all, 11 patients in the CT arm had a scan for ongoing fever to look what's going on. So there's a lot more uncertainty in that CT arm and still looking for answers, and many ended up having a PET, sorry. So just briefly, why did PET meet the primary outcome? What could explain this? And I think there are several explanations. There were more definite positive findings leading to microbiologically defined infections in the CT arm versus in the PET arm versus the CT arm. There were also more clearly negative scans in the PET arm, and a lot of kind of equivocal type findings in the PET in the CT. So I think PET was helpful at both ruling in and ruling out infection more efficiently. And that was also evidenced by less likelihood to have further ongoing scans for the cause of fever in the PET arm versus CT, and also therefore more likely to do IV to oral switch in the PET arm. And I think that all builds up to reducing a risk of reducing length of stay. Just in the interest of time, I won't go into this too much detail. I mentioned that auto is not very well represented in this study, and I think that's just a reflection that these patients are not super high risk and probably don't really need a PET scan or a CT scan that often. Obviously, generalization is to be taken into consideration, given this is experienced PET scanners and people who interpret PETs in infection light in everyday practice versus applying that to other settings. We did include crossovers into the primary analysis, but we were trying to make this a diagnostic approach study, being pragmatic. And many of the scans that are performed on these patients are not necessarily for infection, they're also for other reasons. This study was not blinded, but it's kind of difficult to do that. And just finally, there's always people raising their hands and saying, but what about the cost of PET and how can you justify that? And so on a conservative estimate from Australian reporting, an average stay in hospital for an allo patient is $2,500 and similar for an AML chemotherapy. And the cost of PET is about $1,000 Australian versus about $500 for a CT. And so a $500 incremental cost, if you take that into consideration with 3.5 days reduced length of stay in hospital in the PET arm, you can certainly recoup that cost with just looking at the bed days. But we are doing some formal cost effectiveness analysis to look at that in more detail, which will be published hopefully soon. So in summary, PET was beneficial in reducing the breadth of antibiotics used and more likely to rationalise antibiotics, including IV to oral switch, and may be associated with reduced length of stay and is likely to be cost effective. And we should consider FDG-PET CT scans for persistent and recurrent neutropenic fever patients. And with that, I thank you for your time and your attention and invite any questions.
Thanks, Abby. It's a really very, very impressive study, and anyone who's ever had to undertake a randomized controlled trial, especially in these high risk group of patients, will appreciate the amount of work that went into it. Abby, do you think it has changed practice in our organisation? Acknowledging that we've obviously been very experienced with PETs for quite some time, but do our clinicians believe the results and is it influencing their practice?
I think so. I have to preface it by saying that I haven't had as much time on the wards as, say, yourself, Kaz and Monica, with the acute lukes, given being on maternity leave, etc. But my observation is that I think that the haematologists are using it more for persistent fever and more comfortable with using it, and feel that it's justified based on the improved outcomes we saw with these patients. So I think so. I think it is cutting through.
Sorry, Kaz, you're on mute.
Sorry, I'm trying to protect you from hearing the parrots and the dogs today. Are there any other questions from the audience?
There's nothing in the chat, but as I've mentioned, if you want to ask your question in person, just raise your hand and we can unmute you and allow you to ask your question.
There's quite a few people online. Maybe show a thumbs up if you have been able to easily access a PET for a patient like this in your organisation. and a thumbs down if you haven't.
I guess just while we're doing the thumbs, as I mentioned, we are in the final stages of kind of putting together the manuscript for cost effectiveness. And I think, one battle that we'll go with soon with that great data is to show the cost effectiveness of PET and hopefully improve access for hospitals and patients.
Thanks, Abby. Oh, you're right, Kaz. There's one question in the chat. If you could.
Basic analysis says, what are the risks in PET of picking up disease versus infection? In fact, just because it's labelled glucose, we do FDG glucose, and there's some really exciting work that Abby's going to be leading, which is going to be using labelled nuclear and aspergillus label aspergillus antigens and things like that. We're going to do being targeted PETs, but generally speaking, FDG-PET will pick up both infection and tumour and granulomatous disease. But for those of you who are not familiar, PET is actually a dynamic test. And so the nuclear medicine physicians are able to detect not only the SUV max, but the dynamics of that uptake over time. And what you generally see is that cancer lesions will remain avid and infection lesions tend to have a bit of a washout, so that they are able to, in some ways, distinguish. I don't know whether you want to say anything more, Abby.
Yeah, and I think what's helpful is that the vast majority of these patients are acute leukemia who do not have a solid tumour, or lymphoma, etc., patients who are coming up for allotransplant who are in remission and have had a recent staging scan. And so generally speaking, most of them don't have a solid tumour, and have had recent scanning. So for a tumour to show up in a couple of weeks or 3 weeks is unusual. So and also they're not so tending towards having solid tumours if they're leukemia. So certainly in this patient high-risk neutropenic fever group, if there's an abnormality on the scan, it's far more likely to be infective than cancer.
Thanks, Abby. And that's a great question, obvious to us, but maybe because we've been around it for so many years.
Yeah.
All right. So our next speaker is Gab. So Gab Haeusler is a dual-trained infectious diseases physician in adults and paediatrics. So she holds appointments at Peter Mac, where she leads stewardship, and at the children's where she works heavily with the oncology unit. And Gab has been leading really groundbreaking work in the whole area of neutropenic fever in paediatrics for some time now, especially as part of her own PhD and now in her postdoctoral role. And so it's a very great pleasure again to listen to Gab talking about her work. You're on mute, Gab.
Yeah, I know. I always struggle to find the unmute button when I'm sharing slides. Thank you very much for the invitation to talk today on this topic that is very close to my heart. And I think it's a nice segue from the great work that Abby's been doing to discuss shortening antibiotics in patients with what we typically describe as high-risk febrile neutropenia. And so today, in the next 20 minutes or so, I just want to touch on the Australian PICNIC study, which was a large prospective paediatric febrile neutropenia observational study. Look at some of the evidence for antibiotic duration in high-risk febrile neutropenia and kind of get a sense and understand why we do what we do, or there's a tendency to do what we do, and mention a trial that we've opened recently at the Children's Hospital to try and get a bit more clarity around duration of antibiotics for these patients. So why is it important to be talking about antibiotic duration in febrile neutropenia? We often kind of link and attach back to that issue of antimicrobial resistance, which of course is very important and underpins a lot of the work we do in stewardship. But it's antibiotic and the unintended consequences of antibiotics go far beyond antimicrobial resistance. And again, as Abby showed nicely, there's that increased length of stay and cost, which is often driven by continuing IV antibiotics. There's the direct toxic effects of antibiotics on end organ. There's some really interesting data that's summarised nicely in a systematic review that I've referenced there. that link early childhood exposure to antibiotics with onset of allergy and asthma and other autoimmune conditions. Even more interesting and very relevant to our patient population is that prior antibiotic exposure in some cohorts of patients, particularly patients receiving checkpoint inhibitors, may impact their response in a negative way to that chemotherapy, and also in the stem cell transplant population, that prior antibiotic exposure, particularly very broad spectrum anaerobic antibiotics, may even be driving some of that severe mucositis that our patients get, and even increased risks of graft versus host disease. So lots of reasons for us to be thinking, can we shorten antibiotics that don't need to be continued? And if we think about febrile neutropenia and the risk of febrile neutropenia, and this is, whilst I'm talking a lot about pediatric data today, the same really goes for adults. The numbers that I've quoted here will be a bit different in adults, but really the spectrum of risk is a continuum. Patients are, there's clearly a subgroup of patients that are very low risk of having anything, a severe infection or adverse outcome, and patients that walk through the door in ED that look desperately unwell and we know are a very high risk of having a severe infection. And you can see I've populated this spectrum with some of the numbers that we've found in pediatrics. And so at least 40 to 60% of all comers, so this is kids with solid tumours, kids with acute leukemia, post-transplant, most of them we won't identify an infection and they come into hospital and have a very straightforward course and go home. But despite being really in that low risk group, these kids are often still staying in hospital for 3 or 4 days, or were before we introduced a low risk febrile neutropenia program. And very similar to the adult data Abby showed, is that the mean cost per day of even of these low risk patients is just over $2,000. And then we're moving into that high risk group, and you can see what proportion of kids will have a bacteremia with 13%, and 34% will have any microdefined infection. And it's that group that we really want to be giving antibiotics, and it's that low risk group that we know is very safe and much cheaper and improves their quality of life to shorten their antibiotic courses, to switch them over to oral antibiotics, and to manage most of their febrile neutropenia episode in the comfort of their own home. And I'm really not going to spend much more time talking about this at all today. I've given many talks about our data behind our low risk febrile neutropenia program, and if anyone is interested in implementing or more information about both adult and pediatric low risk febrile neutropenia programs, that's identifying those patients that are unlikely to have a severe infection that can be safely managed at home, I'll just urge you to go to our National Centre for Infections in Cancer website there, and there's adult and pediatric toolkits and all the information you'll need. And so why am I so confident about the low risk febrile neutropenia data? So there's a lot of international data that suggests it's safe to go home early, it's improved quality of life, and it's much less expensive. And we've really shown that in our national pediatric febrile neutropenia study, the Australian PICNIC study, that Kaz Thursky and Monica and the team and the team from Peter Mac have been very involved with along the way. So this was a study where we validated clinical decision rules to try and identify how we can stratify kids with cancer and febrile neutropenia into high and low risk. Alongside of that, we developed guidelines for implementation and care pathways, updated or developed a online education package that's available on Everq, and I've actually just done a revamp of that in the pediatric space. Again, another really useful resource to understand all the evidence behind pediatric febrile neutropenia management. We've updated guidelines locally and nationally and developed those implementation toolkits that I mentioned. Alongside of that, we've implemented the pathway, a low-risk FEBNEUT pathway across the country in paediatrics at all 8 tertiary paediatric hospitals, and have in some of our pilot work evaluated cost effectiveness of that, looking at health-related quality of life and economic impacts of this model of care, and we'll be doing more work on our Australian implementation study in that space in the coming years. And obviously with any study that you do, you identify new research opportunities. And really that where we've landed in our study that we've opened at the Children's Hospital, the early versus late stopping of antibiotics in high-risk febrile neutropenia, because whilst we were spending a few years really focusing on that low-risk population, when we had a deeper dive into the data, which I'll show you in a moment, in the patients with that typical high-risk febrile neutropenia, there was a lot of excess antibiotic use there. And so what do I mean by that? So this is our current standard of care in pediatrics, really across the country, that the median duration of IV antibiotics in children with acute leukemia, so that's acute lymphoblastic leukemia, acute myeloid leukemia, that really is the bulk of pediatric cancer. So 60+% of all pediatric cancers will be an acute leukemia. That even in those kids that have a rapid resolution of their fever, in the first 24, 48 hours, no sign of a documented infection, and a clinically stable but a remaining neutropenic, so a neutrophil count less than 0.5, will stay on antibiotics, at least 6 days, often out to 2 weeks. And if we just look at the AML population, the myeloid leukemia population that typically have those very prolonged neutropenia periods, their median duration is as long as 12 days. Again, in those kids that afebrile, clinically stable. So quite different from the population that were enrolled in the Pippin study Abby talked about, where they were patients that we've excluded all those to look at these antibiotic durations, those patients with persistent prolonged fever or recurrent fever episodes. And trying to understand why these patients do stay on antibiotics for a long time. It's really that dogma, I guess, across the country and really across the world, that antibiotics are often continued until evidence of marrow recovery. And that, what does that translate to in the stem cell transplant population, where patients are going to be neutropenic for 2, 3, 4 weeks, often more? This is a retrospective study done by Eden Andrews, one of the oncology fellows at the Royal Children's Hospital, of the last 125 consecutive allogeneic transplants performed there. And you can see the green, so each line represents a patient. The dark black line is the day of infusion of their stem cells for all patients. The blue vertical line represents the median time to engraftment. The green on this is no antibiotics, and anything yellow or above represents antibiotics. And you can see from that sea of yellow and red, the darker areas indicating multiple different antibiotics during that particular day. There's a lot of antibiotic use in the stem cell transplant population. And in fact, in the first 30 days, the median duration of cumulative antibiotic exposure per patient was 24 days. And there was only a handful of patients, even less, that had antibiotics for less than 2 weeks. I tried to trace back what the evidence behind that continuing antibiotics until evidence of marrow recovery, where did it come from, what gets quoted repeatedly within the literature to try to guide some of those expert opinion recommendations that we see in a number of different guidelines. And where I landed was back in the mid-60s in this paper that, this is pre the era of routine use of broad spectrum antibiotics for febrile patients. And it really is quite confronting data. So after 1 week in patients with acute leukemia, after 1 week of profound neutropenia, the risk of severe infection, I'm talking, bacteremia or other severe invasive infection, was more than 40%. And if they remained profoundly neutropenic for 3 weeks, that risk increased to 75%. And that was associated with a very high mortality. So you can understand in part why there's that anxiety and concern about these patients. But things, it's 2022, this was back in the mid-60s. And if we think using lymphoma as an example, how far we've come with treatments for all leukemias and lymphomas. And, this, I think, figure here really just illustrates nicely the era of chemotherapy, the targeted therapy, and now the immune therapies. And if we overlay that, our approach to febrile neutropenia management, the late 60s, early 70s, it was became more routine practice to start broad spectrum antibiotics until evidence of marrow recovery. And we really haven't challenged that in the same way that the treatments for cancer and leukemia and lymphoma have been challenged to really improve outcomes and improve quality of life for many patients with cancer. And why is that so? So there's limited supportive care trials. There's been a lag in the development of diagnostics and point of care tests for diagnosis of infection, really poor uptake of risk stratification strategies. So we know that that low risk population is very safe to go home early, to stop antibiotics early, but many centres are not doing that. And also limited investments in guideline and care pathway implementation. So just thinking back to that high-risk febrile neutropenia population, the kids and adults that are going to remain neutropenic, get their fever and start their antibiotics. Do we continue antibiotics until evidence of count recovery, or can we safely stop antibiotics before any evidence of count recovery if they're well? So this is a snapshot of results from a Cochrane review that pulled all the randomized controlled trials that looked at this, and there were only 8 included in this, and there's been one subsequent trial that's been published since this review in 2019. And if you just look down for mortality, clinical failure and bacteremia, the relative effect, that overall there doesn't seem to be a difference in outcome in those important components of outcome in patients that have stopped before neutrophil recovery versus patients that have been continued on. But there are a lot of limitations of the existing trials. So there's only been 3 that have been conducted recently, so since the year 2000, and only one of these trials has just focused solely on that high risk population, so the acute leukemics, the stem cell transplant patients, and that trial excluded children. It's often referred to as the How Long study, that did show that stopping antibiotics before neutrophil recovery, not surprisingly, reduced your antibiotic exposure and appeared to be safe, but that study wasn't powered for safety. And then, not surprisingly, given that there's that paucity of robust data to support antibiotic duration in that high-risk population, there's a variety of different recommendations in the literature in internationally published guidelines, anywhere from that continue until count recovery down to the more recent UK guideline that is much more vague and open to interpretation, where it's a continue until response to treatment, irrespective of the neutrophil count. So what we're hoping to do, and I've borrowed these slides from Karin, our PhD student, is to change the quality of evidence in this space from this into this with the ELSA study, so the early versus late stopping of antibiotics. And just a shout out to the incredible team that are working on this trial that we've opened this year. So Colin Butter's a PhD student, our project manager and EMR analyst, which I will talk more about in a moment, and particularly the entire Children's Cancer Centre at the Royal Children's Hospital. So a snapshot of what this trial is looking at. So we're taking all the patients that we would typically not be considering for our low risk febrile neutropenia pathway, where we were transferring them home for care, but those kids that are febrile that come into hospital that are likely to remain neutropenic for at least 7 days or longer. And when they have been admitted and started on antibiotics, if they're afebrile at 48 hours, they've got negative blood cultures, no other signs of an infection requiring IV antibiotics, and they've been clinically stable, they're randomized to stop antibiotics, irrespective of their neutrophil count, or to standard of care. We've left that relatively open. It's difficult to get a group of hematologists and oncologists to agree, to get anyone around the world really to agree on what truly defines evidence of marrow recovery, what threshold do we use? And so people will have differing thresholds that they will accept as evidence of count recovery. Our sample size is 320, and we're currently recruiting at just one site, but hoping to open at other sites. Our primary outcome that we're looking at is a composite outcome. We often use these in pediatrics because it's many of these severe things that occur, fortunately, very uncommon in children. So it's a recurrence of fever or clinical instability, admission to ICU, new positive blood cultures, or death. We expect that 30% of kids in our standard of care arm will have any one of those events happening, most likely to be driven by recurrence of fever, admission to ICU, and death being exceptionally rare outcomes in the pediatric population, very fortunately. And we've based that on data that we've taken from the Australian Picnic study. We've looked at, just looking at the kids that came into the Children's Hospital, Sydney Children's Hospital at Westmead and Perth Children's. About 60% of those would be considered high risk, of which 50% don't have an identified focus of infection and have that rapid resolution of fever, still having prolonged antibiotics. And in 30% of those patients, they get a new fever episode or a breakthrough bacteremia, even if they're remaining on antibiotics. We've got lots of different secondary outcomes that are really important individually, but obviously not our primary outcome, and we'll be looking at these as well. How did we come up with this trial? How did we come up with the primary outcome? How did we come up with the design? We really spoke to all the key stakeholders, and really and use that co-design process for the trial. And at the centre of our key stakeholders is obviously our patient and their parents. And in work we'd done as part of the low-risk febrile neutropenia program, there was that really strong message coming through that, antibiotics make my child feel unwell, they keep us in hospital, tied up to the IV pole, they can cause complications, but really tempered also with, and very appropriately, that is this safe? Is it safe to stop? What does my oncologist think? And I think something that we all worry about as clinicians when we look after these patients, it concerns me that something may be missed if we stop antibiotics, and infections can come on fast, as we know in this population. We also spoke to the treating clinicians of these patients, and again, that safety message came through loud and strong. The nurses and the pharmacists were really enthusiastic and keen about this study, and really keen to be involved and facilitate. Chatting to groups of ID physicians, slightly tongue-in-cheek, but thinking, can't we just stop these antibiotics? We also put the study protocol out to an international pediatric febrile neutropenia guideline panel, just to make sure that our design was something that would truly inform international guidelines. Was our primary outcome acceptable to that group? Was our inferiority margin acceptable? And because this is an entirely embedded design, trial design, embedded into the clinical medical record, we had to make sure that all components of our trial followed routine clinical workflow. And whilst I'm very excited by that, the actual topic that this trial is studying, I'm also very excited by how this trial is designed. And so this trial is what we call a fully automated embedded clinical trial, where we let the EPIC electronic medical record do the screening, prompting clinicians for consent, identifying patients eligible for randomization, and collecting all the outcome data that we need for the primary and secondary outcome measures. So we don't have a dedicated research assistant employed for this trial. To do that, so I'll just spend the last couple of minutes just running you through some of the considerations that we had to think about when we embedded this clinical trial into routine workflow. This is very much a bird's eye view of all the different steps, and it's really supposed to be a busy trial to highlight that patients that come in through the emergency department and are managed in the emergency department or outpatients, which is the first swim lane of this BPM diagram. There's lots of different steps and considerations that are done, even though instinctively we think they come in, get some blood, start antibiotics and go to the ward. There are lots of different times, moments in time, even in that first 4 hours, that different decision making and stratifications of patients can occur. Similarly, in patients with inpatient onset febrile neutropenia, which is the middle swim lane on this, or patients that are admitted from the emergency department, there are many, many different steps and opportunities really for interventions. If we're thinking about implementing results of these findings, opportunities for interventions of stewardship interventions, and our home-based management of some of these patients as well. beyond that bird's eye view, in order to embed this trial into routine clinical workflow, we really had to get down onto the floor and observe how that routine workflow happens. So we asked lots of questions about who's doing what, who are the actors in the trial, and who's, which doctor, nurse, pharmacist has got the patient's bedside notes open on the EPIC EMR when they're doing their ward rounds. And because we knew we had to base some of the clinical trial methodology within the EMR on the concept of best practice alerts, or BPAs, in order to identify the screening and randomized patients eligible for randomization, we wanted to know what the attitude towards these best practice alerts were. And on a separate study on the low risk program that we've done, we looked at the override rate. So that's the ignoring, get out of my way BPA. There's 76% of BPAs for the low risk program were overridden, and only 3% of users completed the desired activity of the BPA. So we knew going into this trial, we couldn't just rely on an alert popping up reminding people to do certain things with the trial. Zooming in on the high-risk population that are eligible for the ELSA trial, you can see that patients that are admitted to hospital, the EPIC EMR just automatically screens them to see whether they're eligible to be consented for the trial. And here is the magic behind all of that. This is 8 to 12 months work of specialist EMR analysts to build all the different test over and over. We did a lot of testing of how this criteria would work. And once the patient has met criteria to be consented, a little banner appears at the side of the EPIC EMR, and the clinical team that are seeing the patient, that knows the patient well, that they have a relationship and the patient trusts, will obtain consent from the patient. I went to do a few consents myself, and they said, "Who are you? No, we're not doing this trial. We want to speak to the doctors that know us best." Once the patient has been consented, there's a button that's clicked within the EPIC EMR, and then the EMR resets and starts screening them to see whether they're eligible for randomization. And again, lots of separate data points went in to try and build that randomization criteria. Whilst 12 look relatively simple, even something as simple as detecting whether or not a patient was tachycardic, had elevated heart rate, needed an additional 14 logic criteria for that. And that's largely to do with all the different age cutoff for tachycardia in children. Once they fulfill criteria for randomization after being consented, the end user, so the clinician on the ward round, will see this little green banner in the side of the EPIC EMR that says they're eligible to randomize. They click on that and follow the instructions for randomization. And then, assuming that this patient has been randomized to the stop arm, then a banner is visible in the side that they're clinically stable and you can stop antibiotics. If our trial was shown to be non-inferior to stop antibiotics before neutrophil recovery, you could see that a nice implementation component of these results might be to just switch off the standard of care arm and have some automated prompts within the electronic record about patients that are clinically stable and might be suitable for stopping antibiotics. As I mentioned earlier, there were lots of time spent on the design and the piloting of, obviously the clinical trial criteria as well, but definitely the build within the EPIC EMR. And we had multiple PDSA cycles looking at how accurately our criteria that we built was screening the patients, identifying patients suitable for consent and then suitable for randomization. And there were various different issues that have come up, a big long list of those. But some of the things that have particularly jumped out at us is, the consent banner not being visible to the most junior doctor in the team, who are the ones that are doing the documentation of the notes, often on a ward round. So we had to open up the visibility of that consent banner to the junior doctors, rather than just having a select group of registrars and fellows that are more senior that could see the consent banner. When we did a cautious go live where we took a patient on every couple of weeks just to make sure everything was working exactly as we wanted. Another great component of this trial is that there's built-in safety monitoring. So we get automated alerts through our in-basket in the EPIC EMR if a patient has any safety event that we need to be notified about. And we are almost have completed building the outcome data collection. So it felt a bit unnerving to start a clinical trial without having the clinical database written, but this is all being extracted in an automated way out of EPIC. And just finally, we're approaching this trial using a hybrid implementation design. And what does that mean and why are we doing that? And this is really to avoid that unavoidable lag between evidence and implementation, and an average of 17 years for us to implement new research findings is often quoted in the literature. And what we do is really as simply as doing the interventional, the effectiveness study, so comparing the two arms of shorter course antibiotics versus longer standard of care, and simultaneously capturing qualitative and quantitative data around attitudes towards prescribing, why people start antibiotics, why they stop them, why they might be reluctant, why they might not be reluctant to stop them. And we're doing that through semi-structured focus group meetings and putting all this information into some themes that will help us with our implementation phase. And really, this is something just finally that we utilize that framework of simultaneously collecting the data and the factors that would influence implementation at the same time in our Australian picnic study, where opened that study where we captured all the data about what was happening with febrile neutropenia, so that data to knowledge component of the trial in 2016. But because we were using that hybrid implementation design, we were really already able to implement knowledge into practice as early as 2019, as early as 3 years after we started that study. And we've opened that up across the country where we're looking at our current practices of this new model of care from early 2020, and where this project's still ongoing, where we're identifying new areas that we can improve on. So hopefully we will follow this same model with the ELSA-FN trial in that high-risk population, and we can really accelerate the implementation phase. So thank you very much for listening. That's all I have. I'm happy to take questions now or at the end if I've gone a bit over. Sorry, Kaz.
It's always amazing to listen to you, Gab. Okay, but we might hold off questions other than if people want to pop things into the QA. I'm just going to ask you one though. You might laugh. On a scale of 1 to 10, how hard has it been to build out the ELSA?
Oh, look, it's not 10. It's not 10 and it's not 1. It's been so enjoyable, really having to think and translate all our clinical definitions into EMR compatible definitions. And it's maybe because I'm an ID physician and I like to problem solve. It's been lots of problem solving and iterative processes, which I really enjoy. So maybe a 6 or 7.
I think it's absolutely groundbreaking, and for any of us online in the precinct, I'm really keen to bring this across to pilot this in the adult leukemia population. I certainly know our haematologists are super excited to be involved in this sort of work. So you're a real pioneer, I think, Gab, nationally around doing the first embedded RCT, I think, as far as I'm aware. You're definitely the first one in Australia. Yeah. Haven't heard
certainly
about
in EPIC. I'm not sure.
Yeah,
other ones are going
fantastic.
on.
Okay, so hold your thoughts. The next speaker also really very fortunate to be able to work closely with, and that's Michelle Yong. She is a infectious diseases physician working with me at Peter Mac, and she leads our clinical trials. Her own PhD was the role of CMV in allogeneic stem cell transplants, and she's an international leader in this field. And I think she's absolutely perfect to discuss this area of antiviral stewardship. For those of us, many of us who actually do the NAPs every year, year in, year out, I'm sure many of us go, oh yeah, it's appropriate. Oh, it looks okay. It's part of a protocol. It's okay. But is it really? And so I'd love to hear your thoughts, Michelle, about what it means to do antiviral stewardship.
Thank you so much, Kaz. I'm just going to share my screen. Okay, everyone can see that?
Yep.
Thanks, Deb. So I'm going to talk about antiviral stewardship and get you all excited about the new frontier. It's a lot less developed than traditional antimicrobial stewardship programs and antifungal programs. So hoping to harness all your experience and enthusiasm in this area. So just to provide a bit of background, viral infections have somewhat of a image problem. So in the general community and in even a non-specialist sort of group, they're often considered asymptomatic and mild, which is true in most cases, and antivirals aren't seeked or sought, and often there aren't any antivirals available. But there are over 200 different viruses which affect us as humans, of which you would have known some of the most common ones are the respiratory viral infections, the latent double-stranded DNA viral infections, of which my love is that of CMV, and which I'll use as an example for antiviral stewardship, and the bloodborne viruses. And probably pre-pandemic, most people thought they're very mild and there's no treatment, but probably the pandemic has taught us that viruses are lethal, how disproportionately they affect the immune-compromised hosts, and that we really need to work harder to ensure sort of preventative and therapeutic measures. So just briefly, for those of you who are unaware, that CMV infection is often asymptomatic. Transmission is often throughout childhood or early adult, and after a short febrile illness, and of which there's no specific treatment, it self-resolves. However, some of these double-stranded DNA viruses set up a latency or dormancy and remain asymptomatic for lifelong within a small but significant proportion of our mononuclear cells. And those who are at risk of CMV are those immunosuppressed groups. And whilst antivirals treat the viremia, it's important that it never is eradicated. And I've certainly treated CMV infections in the renal transplant group up to 15 years post-transplant. So I took this from the NCAS, this lovely figure from the NCAS website, which questions what are antimicrobials, and it's lovely that the antimicrobials against bacteria, of which we heard a lot of, but also viruses, fungal and parasites. And just concentrating on the viral part of it, it does state that many viral infections often do not require any specific treatment, and that is true, and that chickenpox, shingles, flu and common cold are examples of viral infections. But let me tell you, these words, chickenpox, shingles, flu and common cold, send shivers up my spine when I'm treating my immune-compromised host, as they often are disseminated so severe, send patients into ICU, and I've seen them die. So what is different in the immune-compromised host? This is a very basic immunosuppression, but as it pertains to viral infections. So you can be rendered immunosuppressed either through a primary condition, genetic disorder, or secondary through myelosuppressive regimens. And in particular in viruses, I do want to point out the use of steroids, traditional anti-rejection type immunosuppression such as tacro or cyclosporin, the use of T-cell depletion, which is used to prevent graft-versus-host disease, but then renders a patient a very long period of poor T-cell function and patients are at risk of viral infections for up to a year following a transplant. And then how is this different when we think about the concept of antiviral stewardship? Well, a couple of differences. Firstly, a lot of the antiviral stewardship interventions probably how they differ from traditional AMS is that they're much more in the ambulatory setting rather than the inpatient hospital setting. So we need to capture that outpatient setting where they can be living regionally, getting their testing done in multiple different places. The difference also is that with the viruses as opposed to bacterial infections, we have very good sensitive molecular diagnostics. And not only can we detect the virus that's there, which is highly specific, but we also have the ability to look at viral kinetics and quantitate the thresholds. And so that needs to be incorporated into a sort of stewardship program. With regards to the drugs, we have risk stratification of who would be higher benefit of preemptive therapy or universal prophylaxis, and we need to better optimize these antivirals. And we're also behind the sort of antimicrobial space in that ganciclovir levels or antiviral levels in this case need to be further established. And we have Sue-Ann Ho, one of PhD students working on this. And the other major difference is immunity and a test of immunity, which needs to be incorporated. So the risk of ongoing viral infections will change over time. And so we need to incorporate a sort of a test of viral immunity or test of reconstitution. So to understand, and I'm really back at the data generation stage of all of this, I wanted to understand the CMV burden occurring in Australia. And I aim to look at understanding what the impact of it was in terms of economic and health services impact, and also to look at dosing trends for ganciclovir or valganciclovir, particularly in those requiring treatment. So this was a study done at Royal Melbourne Hospital and Peter MacCallum of all consecutive stem cell transplants receiving preemptive therapy, and we compared those with no CMV versus those who needed treatment. And not surprisingly, we found that these patients who required CMV treatment were spending a lot more time in hospital. So 3 versus 2 admissions, and not only that, but up to a month longer higher length of stay within the first month. We were able to characterize what sort of antivirals they were getting. So valganciclovir in about 40% of cases, but there were also a lot of different combinations and switches between Valgan to IV-GAN and IV-GAN to foscarnet, and even a small but significant percentage requiring cidofovir and then back to foscarnet. So a lot of different complicated IV formulations and oral to IV switches. And so Sue-Ann Ho looked at this in much more detail to look at the dosing trends in over 140 specific sort of treatment courses of CMV, and found that whilst the dosing guidelines were initially very concordant at the start when you're first initiating antivirals, that they rapidly declined to only 61% concordance. And we found, a bit surprisingly, that renal function was really, really common within that from the time of starting antivirals. So, and this is due to changes in transplant, your addition of cyclosporin and a lot of other factors going in, just not from ganciclovir itself. And this relates to the risk of neutropenia. So renal impairment together with prolonged antiviral treatment was associated with a relative risk of 2.5 times increased risk of neutropenia. So that prolonged antiviral treatment is somewhere where we can certainly have some interventions to ensure that it's appropriate at that stage. And no doubtly, it resulted in an increased economic cost to our system. So I found that 52% increase in total hospitalization costs within the first 12 months of a transplant. And you can see here on the pie chart, this was consistent across each bucket of costing, whether it's hospitalization, ICU costs, pharmacy costs, and even blood products, likely related to anemia and transplant-related sort of neutropenia and thrombocytopenia. And can I just point out that it's grossly underestimated? This is a inpatient sort of costing only. We haven't even factored outpatients. Very briefly, this is a concept that where there is one viral infection, there is often lots of other infections. And so this is work courtesy of Michelle Yong and Beatrice Sim, where we looked at multiple viral infection burden in the transplant, and don't want you to take anything away from this except that there are multiple viruses occurring at the same time, of which CMV is the most common, but a lot of different interactions there that viruses cause a big burden in the transplant population. The new CMV, there are a couple of new CMV antivirals on the horizon, which is really exciting for me because we've had a number of old antivirals which we've been working with for 30 years and of which there are sort of a lot of limitations with how they can be used because of adverse events. But it's important to recognise that with these new antivirals, we really need to optimise our current antivirals as best as possible in order to preserve and then more appropriately use these new antivirals when they come. So one of the aims of an antiviral stewardship, like the antimicrobial stewardship, is to prevent resistant organisms through better quality use of antivirals. So the incidence of CMV resistance in the haploallo transplant group, the data shows that it can be up to 14%, which is really high. And I was also surprised in the most recent CMV victory study presented at ID Week, comparing universal prophylaxis with Valgan versus Latimavir, that in the Valgan group, 10% of genetic mutations were even found in that cohort. And on the left here is a table that's been adapted from the ASTCT guidelines, looking at the particular risk factors for CMV resistance. And so good understanding of the changing landscape of transplants. So more haploidentical transplants, the use of more T-cell depleted transplants, therefore put the patient at risk of these viral infections for a year or longer. And also the drug-related elements of resistance contribute as well. So I'll just read out that subtherapeutic exposure to antivirals due to non-adherence, dose interruption, and or adjustments due to renal impairment or dose-limiting toxicity is a contributor to CMV resistance, and that prolonged exposure to antiviral drugs in the presence of ongoing replicating virus is a contributor to resistance. So hopefully, to sort of summarise, this is a slide courtesy of Anna Khanina, who's paved the way in antifungal stewardship. I've shown you the importance of why antiviral stewardship would be important. So there's a high burden of disease. It's one of the most common infections following transplant. There are ever-changing new at-risk groups that we need to be on top of. Antiviral resistance I've touched upon. There are limited treatment options up to now. So because of the need for intravenous therapy or neutropenia, it's really important that we optimise the use as much as possible. I've shown how costly it is. What I probably haven't touched upon is how much it impacts on the rest of the transplant in terms of graft survival, graft versus host disease, quality of life of these patients. So if we could eliminate or better manage the CMV reactivation part of it, they would have a much smoother course with the other underlying disease. And immune monitoring is something that is a little bit different in the antiviral space, is that it helps assess the ever-changing risk, and so that needs to be incorporated and is important. However, the goals of stewardship are still the same here, and that's to optimise use, improve patient outcomes, reduce adverse sequelae, in particular neutropenia, to ensure that we are using cost-effective therapy, and to be able to conserve and preserve our current antivirals. So in the literature, there are a number of antiviral stewardship programs available to improve their use, and they're often in targeted high-risk populations. So probably antiretroviral stewardship is probably most sort of described in the HIV population, but less so in the CMV space. And there are two sort of published studies which I'll talk about of CMV, but only in the solid organ transplant field. There is a study looking at ribavirin in RSV in pediatrics, and in some form or another, our use of Paxlovid or antivirals in SARS-CoV-2 positive patients is a sort of form of potential antiviral stewardship. And I'll touch upon our activities that we do in the allogeneic stem cell transplant. So firstly, are these what's known in the literature, just quickly describe a couple of studies of CMV antiviral stewardship in the solid organ transplant group. So this is a US study in Wisconsin, which has a very large outpatient solid organ transplant unit consisting of mainly kidney, but also liver, pancreas, lung and heart. And they identified a number of years ago the problem of really difficult ganciclovir resistant CMV, and also an increasing burden or need to hospitalize patients for IV foscarnet. So then they set up a stewardship program back in 2018 and agreed upon some centre-specific guidelines, which were based upon the third international consensus guidelines of CMV and solid organ transplant. So they had a very sort of robust and sort of agreed upon guidelines, which helps. Great to see again that you can't do this in isolation. It requires a lot of stakeholders and buy-ins from transplant pharmacists, ID physicians, the transplant surgeons and transplant physicians. And that in their centre, antivirals were not a restricted item. So I love their paper for sort of very frankly describing what they did and what they had to adapt and change to. So their first initiative was to use EMR alerts and to get sent CMV viral loads sent to in baskets as soon as they were above the level of detection. And they very sort of humbling acknowledged that this resulted in an overwhelming burden of messages in our inbox. And we all know that there's tiredness of receiving, you don't want to receive 50 alerts in your inbox. So they acknowledged that that was overwhelming. So therefore they identified a much more higher targeted high risk group. And for the solid organ transplant group, that is certainly the D positive R negative group, rather than looking and getting alerts for every single patient. They also acknowledged the difficulties they had with reporting times, standardizations and delays with their local laboratories. And they wrote a lovely paper how this was also made worse with the COVID pandemic. And so they instituted this program only to find that patients were then therefore reluctant to come into the central hospital for their PCR testing. And so it made it somewhat very difficult to coordinate. And they also embraced the shift from using antivirals to a shift at looking at the at-risk population and incorporating cell-mediated immunity 9 months following the transplant to try and embed that in. It was particularly in the D plus R negative group after universal prophylaxis. The first 6 months after that time is very difficult. It's much less about antivirals, but understanding who is at risk. And they did this by using cell-mediated immunity assays. Some of the outcomes they looked at after over 1,000 patient monitoring episodes were really great. And they found that the incidence of ganciclovir resistance, at least numerically, was really much improved. So they had 11 resistant CMVs in 2016. This had reduced down to 0 by the end of the program. There was a much better streamlined care using a centralized approach, and this just delivers good quality of care. It's communication. They had a much more proactive versus reactive approach to CMV, And this improved decision-making on not only antivirals, but immunity and also immunosuppression. And they showed that they were able to reduce CMV treatments from 26% down to 12%. The other study, just to briefly touch upon, was more a pharmacist-driven approach and in the outpatient setting. And this was a large, again, solid organ transplant population, and their clinical problem that they identified that the results weren't received in time. And this was largely driven by much more an ID pharmacist and ID physician, but again, all the stakeholders were there. And they had 3 different interventions: an automatic alert generation. The ID pharmacist then went and looked at a patient profile review and then sent off messages and notifications with a recommendation. And these were highly acceptable. So when they looked at a pre and post intervention type of study, they found that overall, patients were less likely to have very high out of control viral loads due to this program, better CMV clearance. They appropriate started commencement of antivirals within a shorter period of time. Clearance was better, reduced CMV related admissions, reduced CMV disease, and less CMV resistance, if numerically, if not statistically significant. So therefore, I wanted to, last few slides was look at what we're doing here at Royal Melbourne and Peter Mac with our current antiviral activities. So we identified back in 2018 some clinical problems which were affecting our patients and the allogeneic stem cell transplant group. And one of the strengths of this program is that the stakeholder, the transplant physicians and head of department really highlighted that clinical need and really born out of, firstly, was communication of results. So that's what happened firstly. So when was the result going to be available? It wasn't like an FBE where it would be available that day or even the next day. How come there were delays? And we needed a liaison or good way to communicate with micro. There was also a growing high-risk population in the transplant program, so more haploidentical transplants were being done. And at that time, sort of umbilical transplants, where nearly 100% of these patients were having CMV infections. So close and rigorous eye on the CMV viral loads was required. There were a couple of cases of very difficult CMV resistance, so that also drove the need for these activities. And also from a research perspective, we had a number of research studies throughout this time, and it was a good way to try and identify patients and get them onto a study, which, as we all know, leads, it would aim of improving care. So we started a weekly CMV meeting, which was initially face-to-face back in 2019, and then went to Zoom throughout the pandemic. But let me tell you what, it continued on. There were every week, at least 30 to 40 physicians or clinicians are at this meeting, where we go through a list of all the current and outpatient patients with CMV. So in the team are pretty much all the allo transplant physicians, nurse practitioners, and I acknowledge Alex and Ming, who are the ones going through the CMV viral loads each week. ID physician, hematology registrars, a BMT pharmacist, and also transfusion staff. And some of the interventions that we looked at was, firstly, we tackled the CMV viral reporting issue. So improved liaison between the lab and the clinicians. When were the runs being taken? If you get your bloods done at this certain time, it'll get onto the run, which was done twice a week and still is, and then you should get your result by the following morning. So that really helped plan outpatient stays and outpatient appointments. So that was really useful. And we also found there were the missing, we reviewed the missing data. So every week we'd have the high-risk patients, and if it was missing, we'd always question why, who's done the result, have they gone to ICU and we've missed it. So that was a really great intervention that we've had as well. At this meeting, we were also able to discuss concurrent immunosuppression. So Rather than working in a silo, we would say, well, this viral load's going up, but hey, I'm dropping down your cyclosporin, I've just started PRED, or I'm reducing PRED. So we were able to better understand and communicate the context of that CMV viral load. We underwent an individual risk category or stratification at that time, so viral load be going up, but we'd say, hey, there are pos transplants, so let's just wait on that for a while. And then we agreed upon threshold for treatment. And again, a very proactive approach. So if the viral load reaches this, at this point by next week, let's start valganciclovir at that point. And we also agreed upon the choice of antiviral and the mode of administration, whether oral or IV, and what particular antiviral should be given. So that was also one of the interventions. And I don't have specific data, but some of the really lovely outcomes that have come out of this have really been improved communication, not only between specialties, in particular ID, microbiology, the transplant physicians, hematologists, but also intensive care units, but also across the craft groups of interest. So not only medical, but nursing, pharmacy, research, and there's a lot of good buy-in at these meetings. We've been able to early identify at-risk patients, to initiate appropriate antivirals, as I said, dependent on if the next viral load reaches this threshold, or if they're going to remain. The other great example is, they've got bad GVHD, I'm going to hit them with 1 mg per kilo methylpred, so we therefore anticipate that CMV viral will go up. We've also been able to discuss neutropenia and adverse events, and not only to say, let's give some GCSF and persist with the Valgan, or look, that neutropenia has been going on for a while, we need to get him off that and switch over. It's allowed for better planning of admissions, particularly for the nursing, both inpatient and outpatient nursing staff. So, well, we are planning IV Foscarnet, therefore, when they're seeing them at the outpatient, we can just discuss that early and get that concept in early to the patients. Another great aspect of the program has been identification of research participants, and we've had a number of research projects during that time, of which we've recruited really well, because we've been able to identify patients to their meet eligibility, and then it's a group effort. Yes, no, can they go on to study or not? And that's been really terrific. And we've also just expanded it a little bit as well. So it's not just a dedicated CMV, but we also talk about other viruses, EBV, other viral infections, and also not only antivirals, but other T-cell related therapies. So that's the next frontier. So to conclude, antiviral stewardship is relatively new compared to the AMS programs that are well established, so I hope to follow that lead. There are a lot of research and implementation opportunities, so shameless plug for anyone out there who's interested in this area and would like to see this be built up with a very targeted and very invested, captivated population, not only from the patient side, but very supported nurses and clinicians interested in this area. I'd like to evaluate our current activities to formalize a program a little bit more. Plans to incorporate novel aspects such as a CMV-specific immunity test. Sue-Ann Ho's working on therapeutic drug monitoring and has some really exciting novel things about potentially just using blood spot analysis as an outpatient, sending that in and getting some sort of level there. And we need to better include the new antivirals, which will hit our shores very soon. So with that, I want to thank you, and that's my email address, and invite any questions, although we are running a bit over time. Thanks.
Thanks, Michelle. It's actually quite a substantive area, isn't it? I think it really does need a lot of attention, and I've just reflected that we actually haven't done an evaluation of the NAPS data with regards to antivirals, so maybe that can be a job for you and your team.
That would be lovely.
In the interest of time, I did want to make sure that Anna had enough time to present today, because it's a very important presentation. Anna is one of our PhD fellows at the NCIC. She is a senior antimicrobial stewardship pharmacist. She's a program lead for one of our project runs using novel data science to support the surveillance of invasive fungal infections. And as part of that whole project, she has actually led the design and implementation of the antifungal NAPs, which is a hugely important tool now. It is a real deep dive look, and we're really keen to get your engagement in doing the first audit. So take it away, Anna.
Thank you so much, Kaz. Hopefully you can see my slides okay now. So I'll be talking a little bit, giving a bit of an introduction into the antifungal NAPs, or the Antifungal National Antimicrobial Prescribing Survey, and I'll give a quick demo just to give you an idea of how to access it, what's involved, and how you can get started and get involved. So I'll just talk a little bit about why antifungal stewardship is important, how we went about developing the antifungal NAPs. We'll talk about that briefly, how it should be performed. I'll give a bit of a demo, as I mentioned, and talk about how you can get started. All right. So this slide will look familiar from Michelle, but we just wanted to talk briefly about why antifungal stewardship is important. These infections, so invasive fungal infections, are relatively rare infections. They tend to affect immunocompromised patients, particularly those undergoing treatment for cancer, in particular hematological malignancies. But when these infections do occur, they have a really high morbidity and mortality. Patients can really suffer from not just the infection, but also it may delay their underlying treatment. So if they're undergoing chemotherapy, for example, they might need to reduce their intensity or delay their start of the chemotherapy while the fungal infection is being managed and to get under control. And that can then impact their underlying disease as well. We are seeing increasing at-risk groups, and therefore we are seeing greater use of antifungals for both prevention and for treatment of invasive fungal infection in our hospitals. There is some increasing antifungal resistance, particularly for triazole agents. And we have relatively limited treatment options. There's only a few classes of antifungals that we have today. There are some new agents that are on the horizon that are being trialled at the moment, but we need to make sure that we preserve and use the agents that we have today as well as we can. These infections can be very costly to manage, and there are some limitations to using these drugs. There's lots of drug interactions that make it complicated, contraindications, cost considerations, having to understand who's at risk and who requires prophylaxis. So it's a complicated area that does require expert input. And international studies into the appropriateness of antifungal prescribing have found that there are definitely areas for improvement. Just an example of a few studies from overseas looking at the quality of prescribing in the hematology oncology area found an appropriateness rate of only about 30 to 55%. So lots of room for improvement, things like appropriateness of duration of prophylaxis or empiric therapy, dosing, appropriate use of therapeutic drug monitoring. So lots of definitely room for improvement there. So what is antifungal stewardship and what are the goals? And really it is very similar to antimicrobial stewardship. Our goals are the same, really, to optimize antifungal use, improve patient outcomes, reduce adverse sequelae, ensure cost-effective therapy, and conserve the agents that we have today. I guess there's some additional complexity in antifungal stewardship, which really does require expert input, people that are really familiar with diagnosing invasive fungal infection, understanding the monitoring that's required, the tests that are required, who's at risk, and then also really having a good in-depth knowledge of prescribing of antifungals and understanding pharmacokinetic considerations and how to implement therapy drug monitoring and how to use that effectively. The guidelines, there have been some guidelines published around antifungal stewardship implementation. So there were, in 2020, there were international guidelines that were published, and in 2021 there were Australasian guidelines as well. And both guidelines really do stress the importance of collecting data to drive quality improvement and making sure that we have an understanding, not just in the volume of antifungals that are being prescribed, but also the quality and the patient outcomes. But the guidelines don't give too much direction about how exactly to do that. So that was sort of a challenge that we took on at the NCAC together with our colleagues over at NCAS. And so first of all, we had a look to see, well, can we use the hospital NAPs that we have today? Can we use that to look more deeply at antifungal prescribing? And what we found was, unfortunately, it doesn't quite allow us to do that in the way that we would like to. The antifungals are point prevalence methodology, so you get a relatively small number of antifungals that you're looking at in each audit. You can only assess treatment at one point in time. We don't collect data on patients' history and their risk for invasive fungal infection, so it's harder to, I guess, interpret the data in a very meaningful way. It doesn't collect some really specific antifungal specific outcomes, and there's no outcome metrics at the moment. So what we decided was that there needed to be a deep dive audit specifically for antifungals. And so just briefly talk about the development. We had a look at the literature, see does something exist out there that we can implement and take on here in Australia. We looked at what metrics are used, what audit tools are used, what methodologies are used, and we found that there's a huge variety of different ways that this is being done. So what we decided to do was what's called a Delphi study, where we asked international experts in the area what they felt were important metrics in the area of antifungal stewardship, what's important to measure, not only in the quantity of prescribing, but also the quality and patient outcomes. And not just what was important, but what's actually feasible. What can we do in our routine practice that we're going to be able to do consistently ongoing? And based on that, we then took the results and we did an extensive co-design with a multidisciplinary steering group to develop the content and definitions that would then go on to be incorporated into the antifungal NAPs that we went on to develop. We developed it with a team over at Guidance, and we piloted the antifungal NAPs across 8 hospitals. We got them to test the methodology, give us feedback about usability, and we did get a lot of feedback that we then incorporated and optimized the antifungal NAPs. And then the last thing that we've just recently finished off is a validation and reliability study. So we didn't want to just create something and put it out there. We wanted to make sure that it was something that could be used consistently and reliably by different people at different times, so that if I'm auditing today and my colleague comes along and audits the same patients tomorrow, that we're going to get the same sort of results. Well, probably not going to be 100% the same, but as close as possible, so that we know that these are genuine, reliable results that we can then use them to compare to other hospitals and over years and to track our progress over time. So we've just completed this study and we got some really great learnings around how we can optimize the use of the antifungal NAPs to make sure that it is as reliable as possible. So this is what we've come up with today, is we have the antifungal NAPs, and the antifungal NAPs really allows for a nice flexible audit methodology. You can audit how you want, basically. You can choose to audit a drug base. So you might want to focus just on what's happening with your voriconazole, or you might be interested in all of your echinocandins, for example. You may be interested in what's happening with your antifungal use in your BMT patients, for example, or you might want to do an indication-based audit. You might be interested in what's happening with our candidemias at the moment. So it allows for some flexibility. Great thing is that you can assess each phase of antifungal prescribing throughout the patient's journey. So they may come into hospital on nothing, or they might come in on some antifungal prophylaxis if they're a high-risk patient. At some point during their treatment, as Abby was describing, they might have prolonged neutropenia, and so they might start on empiric antifungal therapy for a suspected infection. And then once we have more details and more diagnostics, they might then transition to directed therapy. So the antifungal NAPs lets us to look at all of those phases of prescribing. Oops. It also lets us collect some detailed patient information, and in particular information about a patient's risk of invasive fungal infection. So we document what was their immunocompromised condition, if it's a hematological malignancy, what management they received, and risk stratification according to the most recent Australian guidelines for antifungal prophylaxis. We've incorporated new quality metrics that we ascertained from the Delphi study. So in particular, looking at therapy, drug monitoring, drug interactions and drug contraindications as well. We incorporated some outcome metrics around the incidence of invasive fungal infection and breakthrough infections, whether or not diagnostics were done, and then also mortality outcomes for our patients as well. And we will soon have some reporting and benchmarking available. So we'll have really detailed reports around the quality of antifungal prescribing, patient outcomes. These reports are going to be really nice and interactive and will allow benchmarking between similar facilities. And I should say it is available now for all Australian hospitals. So if you're interested, please get in touch, get started today, and I'll talk a little bit more about how you can do that. This might be familiar to NAPS users. This is the appropriateness matrix, and we've modified this for antifungal specifically and added in some additional elements there. But really want to stress how important it is when you are doing the antifungal NAPS audit to come back to this regularly and to be really, really familiar with it. What we found in our validation study was that while somebody might have picked up that a dose was incorrect or there was a drug interaction, they might have still called something adequate potentially when, according to our appropriateness matrix, it possibly should have been a suboptimal or an inadequate classification. So just for consistency, making sure that we're all auditing in the same way, we really want to encourage people to come back to this and be really, really familiar with it. So who should be involved in the antifungal NAPS audit? So typically, I guess, in most NAPS audits, you usually have your AMS pharmacist and your ID physicians involved, and they should definitely be involved in the antifungal NAPS. But we really encourage you to include your specialist pharmacists as well. So pharmacists that are practicing in your high use areas such as oncology, hematology, ICU, solid organ transplant, neonates as well. In our validation study, we included specialist pharmacists, and we found that they had the highest accuracy in their assessments of appropriateness. So they have some specialist knowledge, particularly around drug interactions, contraindications, patients' risk, that can really benefit the team. And also including a specialist physicians is essential. And we want to make sure that your hematologists, your transplant physicians, that they're aware that you are undertaking the antifungal NAP, so that when you have the results and you come to them and say, we think there's a problem here and we'd like to improve management in this way, they're not surprised that you've been looking at their prescribing, and they're supportive and work with you rather than against you to implement quality improvement. So really, really important that it's a multidisciplinary team. So what can you audit? As I mentioned, it's quite a flexible audit methodology. You can look at, for example, all of your antifungals. So you might choose to do all of your systemic antifungals that have been prescribed over a 3-month period. And so here you'd be able to go either to your EMR if you have one to look at inpatient, and you can also include outpatient orders. If you don't have an EMR, you can go to your pharmacy dispensing records or your restricted antimicrobial list like guidance, for example. And this can be done health service wide, or you might want to target a high prescribing unit. You can focus on a drug rather than all drugs. So you might say, I'm interested in what's happening with our posaconazole or our echinocandins, for example. You can focus on a patient type. So you might want to do all of your lung transplants in a period of time, or you might want to look at all of your B&T patients that have been admitted in the last 6 months and look at how their prophylaxis has been prescribed. These can be tricky to identify. You'd need to either use your EMR to look at lists of admitted patients or for that particular unit, or use unit records for admitted patients. And here the good thing is that you can also include patients that are not prescribed antifungals. So especially in a high risk area like BMT, for example, if you're doing the audit and you come across someone who's not on antifungals, you might wonder, are they a risk? Should they have been on prophylaxis? And if not, why not? And that's an area that you could identify that is unique to the way the antifungal NAPS is done. And finally, as I mentioned before, you can also do the audit by indication type. So you might want to focus on your candidemias or all of your invasive mold infections, and you can do this by contacting the lab to ask for example, all of your blood candidas that they've seen or infection surveillance records. So we are undertaking our first national benchmarked audit. So what we're aiming to do is every year to have a specific kind of audit to benchmark. I think that if everyone's doing something different all the time, it's really hard to compare. So if one hospital's auditing just their cancer patients and someone else is auditing their solid organ transplant patients, and someone else is auditing the whole hospital, it's hard to benchmark. So we're aiming to have a specific kind of audit that we're going to do every year. So for our very first one, to get everybody familiar with the antifungal NAPs, we're encouraging hospitals to audit all antifungals prescribed at their hospital. If that is not feasible, then to target specific drugs or classes, starting off with amphotericin B, moving on to then including mold active azoles, and if you can, echinocandins as well, and then the other agents, so fluconazole, terbinafine and others. And we're aiming to have all the data submitted by the end of February so that we can analyse and then provide some benchmarking reports as well. I was going to do a really brief demonstration about how to access it. So to get into the hospital NAPs, into the antifungal NAPs, you log into your normal NAPs website. You can, if you don't have an account already, you can register. So once you're logged in, you just have to pop into the hospital NAPs. You'll see there's not an antifungal specific tile. It lives within the hospital NAPs. In the resources tab, you'll be able to see that we have some resources specific for antifungal NAPs, such as a user guide, a paper data collection form, our appropriateness. We've got some case examples, which I think are really great. And they go through some really common knowledge gaps that we sort of saw during our validation study. And it steps you through how you would conduct that audit. And very, very importantly, we have our e-learning module, which is developed specifically for the antifungal NAPs, and it's mandatory to do before you can finalise any data. But my suggestion is that that should be the first place that you get started. Once you've had a look at all the resources, you head over to the My Surveys tab just up here. You create a new survey. Make sure you choose the antifungal NAPs methodology. You choose your name. I'm just going to call it demo. Today is the 24th of the 11th. And then once you've created your survey, you then pop over into your patient data tab. You find that survey that you've created, and then you can add a new patient. And what you'll see is that we have some additional tabs that you don't have with the hospital NAPs. So you've got your patient information, and here we collect things about their immunocompromising condition as well. We have information about the patient's adverse drug reactions that they've had in the past that might prevent them from having a specific antifungal. You can document what antifungals were prescribed. And then also the patient's outcomes can be documented here as well. So there's quite a bit of information to collect there. Whoops. So how should you get started? So first thing is, if you're interested, is to assemble a multidisciplinary auditing team and to decide what it is that you're going to audit, whether it's going to be drug specific, patient specific, time period specific. Make those decisions. Get everybody in the team to complete the e-learning module as a starting point. Read through all of the resources and that we've got up there, including the case examples and the user guide. And then you can begin auditing, and you can either do this on our paper data collection forms and then enter it online, or you can enter it directly online, whatever's more convenient for you. That was a bit of a whirlwind into an introduction into the antifungal NAPs, but hopefully it's given you a little bit of a taste. This is our project team. We've worked hard to create this over a couple of years. So yeah, that was all. And if you have any questions, you feel free to give me a buzz, contact me on my email, or the NAPs support team can help you out as well. Thank you.
Brilliant, Anna. Lots of claps. So I think there's going to be lots of excited people. Can I just clarify, Anna, when you say do all antifungals, do you mean submit maybe 30 to 50 patients or scripts, like what, a little bit more clarity for the audience?
Yes, of course. So what we recommend as a minimum is to do at least 30 prescriptions or 1 month worth of prescriptions for your whatever it is that you've selected as a minimum. You can of course do more than that, but you want to have enough data to have meaningful information to be able to implement, to analyze and implement changes if need be. So a minimum of 30 patients or prescriptions or a month data.
And is it just focusing on the hematology oncology patients, or can they go use anything?
So for our first benchmarked audit, you can, and we encourage you to do the entire hospital to see what's happening throughout the hospital. As we go through next year, potentially we'll focus in specifically on the haematology population, but for the very first benchmark audit, we're encouraging you to do it hospital-wide.
Thanks, Anna. So we've got a few minutes left for questions from the audience. No questions silly, no questions too silly or dumb. Please just ask anything. We've got some amazing experts online. Do any of our panel members want to make any comments on each other's talks or areas?
I think that Gab's work with ELSA and the EMR EPIC is super duper exciting, and yeah, it'd be really kind of looking forward to trying to translate that into the adults. And it's really quite, yeah, very exciting.
And all our New South Wales participants online, we hear that you're going to be going through the EPIC journey. So good luck to you.
Yeah.
It's an extremely steep learning curve.
Yes, lots of, hopefully it's as easy as cutting and pasting the script, Abby, but I think there'll be some more implementation issues that we identify.
Something tells me it won't be that, because nothing's ever as easy as you think.
I feel the more embedded clinical trials we do, the more we will collectively learn and be able to share. I'm hoping that the scripts that we write to, you know, even just for the phenotyping of the patient population will be able to be used for other studies. So,
and I think just stewardship and all the platform studies and adaptive trials, it's just ideally suited, embedded trials, to provide decision support and opportunities. I think it's really exciting.
It's more than just comparing two different treatments. It's really comparing two different kind of pathways of care.
Yeah.
Trials.
Courtney's actually hid herself, so I would actually like to extend a word of thanks to Courtney Rano, who is my postdoc across at the Doherty with me with NCAS, and she has been an absolute superstar this last week. She has literally been working day and night to put on the forum, all the webinars, to coordinate all the speakers, to sit on every panel. Really, you know, I don't know, you've been amazing, Court. So thank you, and lots of thanks and appreciation coming from the audience as well.
Thanks, Kath. That's not why I unmuted myself, but I very much appreciate the thanks.
So it's the very last webinar this afternoon, which I'm going to jump on shortly, and that is a really, really important aged care webinar. And in fact, I think typically it's the one that has actually the most participants every year. So we know it's an area that is just completely unmet and untapped with regards to antimicrobial stewardship. So and a shout out to Graham online. I don't know if Graham Chesterton's still online, but I've seen you at every single session. So I think he gets the award, doesn't he? For
I think he just left, but maybe he's gone straight to aged care. Maybe that's why.
Yeah, no, it's good. I am reflecting that I probably should have taken conference leave this week, but anyway. All right. Well,
I've put the link online in the chat for people to jump straight into the aged care one if they're interested.
So Gab, Michelle, Anna, Abby, thank you so much for your talks today. Everything has been recorded, so we'll be putting it up onto the NCIC website as well as NCAS. And for those of us who are part of NCIC, we're looking forward to a special day tomorrow with all the investigators getting together. So thanks everyone for joining and catch up.
Thanks so much.
Thank you.
Thanks, Courtney.
Thanks, guys.